This is Debbie Bucher with Parkland College Nursing Program, and today we're going to look at altered level of consciousness as well as seizures. And I want to take the time out to go over the altered level of consciousness because we talk about several things this semester where intracranial pressure is important, particularly increasing intracranial pressure. We'll be talking about strokes, we'll be talking about brain tumors, brain abscesses, brain infections, head trauma, head injuries, that sort of thing. So I wanted to go ahead and go over the altered level of consciousness and level of consciousness since we're going to be dealing with it in several different weeks content here. Besides, also we will also be looking at seizures as well. So I'll do the altered level of consciousness or management of patients with neurological dysfunction, and seizures. I will cover that today. Okay. Those are the objectives. So altered level of consciousness, it's really important that we are assessing all of our patients when we go to see them during clinical for their level of consciousness, because level of consciousness is one of the earliest indicators or change that potentially could mean an increase in intracranial pressure, which is very important to understand and to remember this and to assess level of consciousness on every patient that you are caring for in your clinicals. So level of responsiveness and consciousness is the most important indicator of the patient's condition that you will be assessing. Altered level of consciousness occurs when the patient is not oriented and does not follow commands or needs persistent stimuli to achieve a state of alertness. Level of consciousness is on a continuum that starts with normal alertness and full cognition and then goes to the other end of the spectrum of consciousness to coma. Altered level conscious is not the disorder or the diagnosis, but the result of a pathology, again, such as a brain tumor, stroke, head trauma, that sort of thing. Coma is when somebody is unconscious and they're unarousable and unresponsive. Actinic mutism, which I will not have this actinic mutism on a quiz or test, but it's the definition of unresponsiveness to the environment, makes no movement or sound, but does sometimes open the eyes and can follow people. Persistent vegetative state, which I think we've all heard about that, is these patients do not have any cognitive function, but does have sleep-wake cycles, completely unresponsive to psychological and physical stimuli, and the patients are being kept alive only by medical intervention such as a feeding tube or a ventilator. A locked-in syndrome is another state of consciousness, it's the inability to move or respond except for eye movements due to a lesion affecting the pons. And just a review here from your biology is the pons is part of the brain that relays signals from the forebrain to the cerebellum that includes sleep, respiration, swallowing, bladder control, hearing, equilibrium, taste, eye movement, facial expressions, facial sensation, and posture. So your pons, does have quite a few things that it does. And coma, again, is the state of unarousable unresponsiveness and really lacks purposeful responses to internal or external stimuli, but they may have non-purposeful responses to pain. Okay, so nursing process, care of the patient with the altered level of consciousness. Starting with the assessment, you're going to be assessing for the verbal response, how alert are they, their motor response, and also are they posturing, what is their respiratory status. You check their pupils. What are their pupils doing? Do you see anything that could be indicative that there might be an issue by looking at the pupils? Checking reflexes. There also is a chart on the cranial nerves. You also want to be proficient in testing cranial nerves, particularly if your patient does have a neurological diagnosis going on. But page 1976 will list that. I know Ms. Bosch gave you all, I believe, a worksheet on that. So if you still have that, you might want to take that with you to clinical, because I think it's just kind of nice to be able to do that people who are, cooperative with you, just to kind of give you some more practice doing it. So, but an altered level of consciousness is a result of can be the result of many different things, such as, again, head injury, stroke, etc. Use of the Glasgow Coma Scale is very important for somebody that you are monitoring for increase in intracranial pressure, and it's best eye movement, best motor, and best verbal. So again, you can check Chapter 65 for the different cranial nerves that you can assess, or use your information that Ms. Bosch gave you in fundamentals. And when I'm talking about the posturing, this is what you'll be seeing, and this is actually posturing that is seen when somebody is really having certainly very increased intracranial pressure. So your figure A is decorticate to the left is called decorticate posturing, and that's where there's flexion of the upper extremities and internal rotation of the lower extremities with plantar flexion of the feet. And then B, or to the right, is deceberate posturing. This involves extension and outward rotation of the upper extremities, as well as plantar flexion of the feet. So you may or may not see this. If you're working on a neuro 4 or neuro ICU, then you may see this. So nursing diagnoses that you will be looking at for somebody with an altered level of consciousness is ineffective airway clearance, risk of injury, so you want to keep these people safe, deficit fluid volume, impaired oral mucosa, so oral care is very important. Certainly risk for impaired skin integrity and impaired tissue integrity of the cornea, ineffective thermoregulation, impaired urinary elimination and bowel incontinence, disturbed sensory perception, and interrupted family processes, to say the least. Collaborative problems, again, the patient may have respiratory distress or respiratory failure, pneumonia, aspiration, pressure ulcer, deep vein thromboses. And of course, our goals and outcomes, we obviously want to maintain a good, clear airway, protect the patient from injury, good fluid volume balance, maintenance of skin integrity, absence of corneal irritation, effective thermoregulation, and accurate perception of environmental stimuli, as well as you want to help maintain an intact family or support system, as well as absence of complications. So lots of nursing diagnoses that are entailed with these patients, so very complex. So one of your interventions you're going to want to do is, because safety is so important here, we want to help compensate for the patient's loss of protective reflexes, and the patient is unable to assume responsibility, where the nurses assume responsibility for total patient care of the patient. And protection also includes maintaining the patient's dignity and privacy. So one of your biggest things, as you have loss of protective reflexes, and includes, of course, airway. So your patient, if they're unconscious, is not going to be able to protect their airway. So that's really, when you're thinking about things that are, a priority, obviously maintaining a patent airway and maintaining oxygenation is going to be really number one, of course. So this is why it's intervention number one. This is probably the most important one that you will be, obviously, concerned about, and trying to do everything you can to maintain that patient's airway. So again, you're going to be doing frequent monitoring of the respiratory status, including auscultation of lung sounds. You want to position the patient to help promote accumulation of secretions and prevent obstruction of the upper airway. Head of bed is usually elevated to 30 degrees, sometimes 30 to 45 degrees, depending on what your provider orders. They may also be on a lateral or semi-prone position. And again, you as a nurse, you may need to be providing suctioning, oral hygiene, and our team may be doing chest physiotherapy as well. So again, maintaining the airway is one of the most important things that we can do as we care for somebody in an altered level of consciousness state. So, and again, we want to do frequent turning, assessing the skin frequently, good positioning, passive range of motion, and we may need to use splints or foam boots, specialty beds as needed. Clean eyes with cotton balls moistened with saline. Artificial tears may be prescribed. You want to make sure you're helping to protect the patient's eyes. Use eye patches cautiously because the cornea may may come in contact with the patch and maybe scratch it. And again, really good oral care is needed to help prevent infection from that away too. So again, maintaining airway, extremely important. And next, you're maintaining fluid status. So you're going to be assessing the fluid status. And now, promoting bowel and bladder function, you want to assess for urinary retention and urinary incontinence. Patient may require indwelling or intermittent catheterization. Patient may need a bladder training program. Assess for abdominal distension, potential constipation, and bowel incontinence. Monitor the bowel movements and promote elimination with stool softeners, glycerin suppositories, or enemas as indicated and ordered. Diarrhea may result from infection, medications, or increase in osmolarity in IV fluids. You want to, as you're caring for a patient who is having changes in their level of consciousness, you do want to still talk to that patient and touch the patient just like you would anyone else, and encourage the family to talk to and touch the patient as well. We feel like, and in the nursing and medical profession, that people, like, one of the last senses that people will lose is their hearing, and so I believe that people can hear even if they're in an altered level of consciousness. So that's my belief. So go ahead and talk to the patient just like you would, anyone else. You want to help maintain a normal day-night pattern activity. Orient the patient frequently, unless it causes him to be irritable, and then maybe not the best idea. And when a patient is arousing from coma, a patient may experience periods of agitation. So you may want to minimize stimulation at this time while they're waking up. You also want to provide programs for sensory stimulation, allow the family to ventilate and provide support, and reinforce and provide consistent information to the family. And you may also refer the family to support groups, maybe say, stroke support groups, or, head injury support groups. So is the following statement true or false? The earliest sign of increasing intracranial pressure is a change in level of consciousness. And if you said true, you would be correct. The earliest sign of increasing intracranial pressure is a change in the level of consciousness. Slowing of speech and delay in response to verbal suggestions are other early indicators, but the main one is the change in the level of consciousness. So intracranial pressure is the force that's measured in the brain, in the cerebrospinal fluid compartment. Usually the intracranial volume is constant and maintains the balance between the brain, blood, and cerebrospinal fluid. If the volume of any of these three components changes, then the intracranial pressure could change as well. And the body can adapt in three different ways to changes in the intracranial pressure, and that is CSF volume can be altered by absorption or production and may move fluid to the spinal subarachnoid space to allow more room. Secondly, there may be cerebral vasoconstriction or dilation and changes in venous outflow occurring. And third, the brain tissue can compensate as a result of the distension of the dura or compression of the brain tissue. The skull is a closed area with three parts, again, as we talked, the brain, blood, and cerebrospinal fluid. About 78% is the brain, the blood comprises about 12%, and cerebrospinal fluid makes up about 10% of the volume in the skull. And under normal conditions, the intracranial volume remains relatively constant, and the balance among the three components of the of the brain tissue, blood, and CSF will maintain the ICP. And the ICP is usually measured in the ventricles, subarachnoid space, subdural space, epidural space, or in the brain tissue using a pressure transducer. Normal intracranial pressure ranges from 5 to 15. A sustained pressure greater than 20 millimeters mercury is considered abnormal and must be treated. As volume increases in the intracranial space, the intracranial pressure increases and decompensation occurs, which then results in a compression and ischemia. And cerebral blood flow ensures the metabolic needs of the brain and maintains cerebral perfusion within normal limits. The brain does have autoregulation, and this is automatic adjustment in the diameter of the cerebral blood vessels by the brain to maintain a constant blood flow during changes in arterial blood pressure. And again, we can see increasing intracranial pressure in patients in stroke and head injury patients. Cerebral blood flow is about 50 milliliters a minute, and it's critical to maintain the blood flow to the brain as it needs the oxygen continuously. The brain typically uses 20% of the body's oxygen and 25% of the body's blood glucose. And changes in the intracranial pressure related to cerebral perfusion pressure. If the cerebral perfusion pressure goes to over 100 or decreases to less than 50, then these people will experience they may very well experience some type of neurological damage. So typically we'd like to see the cerebral perfusion pressure, normal is 60 to 100. We prefer to see it maintained about 70 to 80. And again, normal perfusion pressure is 60 to 100, but we try to maintain 70 to 80. And less than 50 is associated with ischemia and neuronal death. Less than 30 is incompatible with life. Okay. And the Monroe-Kelly hypothesis is because there is limited space in the skull, an increase of any one of the components of the skull, brain tissue, blood, cerebrospinal fluid, will cause a change in the volume of the others. Compensation needs to occur to help maintain a normal intracranial pressure and is normally accomplished by shifting or displacing cerebrospinal fluid. With disease or injury, intracranial pressure may increase. An increased intracranial pressure decreases cerebral tissue perfusion and thus leads to ischemia, cell death, and further edema. Brain tissues may shift through the dura and result in brain herniation. Usually when brain herniation occurs, then the patient is in a demise and most times will not recover from that. And again, autoregulation refers to the brain's ability to change the diameter of blood vessels while helping to maintain cerebral blood flow. CO2 also plays a role. Decreased CO2 results in vasoconstriction, and increased CO2 results in vasodilation. And again, the Monroe-Kelly doctrine states that the three components must remain at a relatively constant volume within a closed skull structure. If the volume of any one of these three components increases within the cranial vault, then the volume from another component is displaced. The total intracranial volume will not change. So again, brain tissue has limited space to expand. Compensation is usually completed by displacing or shifting cerebrospinal fluid. And okay, yeah, and again, the normal intracranial pressure is 5 to 15 millimeters mercury. And again, the cerebral perfusion pressure is the pressure needed to maintain blood flow to the brain, usually between 60 and 100. And if we can keep it to 70 to 80, that will usually be the best. And again, cerebral perfusion pressure is closely linked to intracranial pressure. This equation there that you see for the CCP will not be tested on that, but I just wanted to let you know that. And we've already talked about if the intracranial pressure is higher or lower, that it will probably cause some sort of neurological damage. Okay. And there's 4 stages of increasing intracranial pressure. The first stage, the brain is still able to compensate for the increase in pressure. Autoregulation is intact by the brain. Stage 2, the brain's ability to compensate decreases and are at risk for increased intracranial pressure. Stage 3, there's a major reduction in the brain's ability to compensate, so any small addition of fluid will create a great increase in the intracranial pressure. There's loss of autoregulation, and manifestations of increasing intracranial pressure, these are important to remember, are headache, changes in level of consciousness, which is usually the first change related to the increasing intracranial pressure. You may also see pupil responsiveness changes. You may also see a rise in the systolic blood pressure with a widening pulse pressure, bradycardia with a full bounding pulse, with respiratory changes. If you do see this, this is known as the Cushing's triad. This is indeed considered to be a neurological emergency. And stage 4 is where the intracranial pressure has risen to lethal levels and brain herniation occurs with brainstem death and most likely will end in the patient's demise. Okay. All right. Okay. So again, manifestations are changes in level of consciousness. That's the most early indicator. And restlessness, confusion, increasing drowsiness, increased respiratory effort, purposeless movements also are signs and symptoms of this. You may also see pupillary changes and impaired ocular movements. You may see weakness in one extremity or one side. Patient may complain of a headache that is constant, increases in intensity, or aggravated by movement or straining. And nursing diagnoses associated with this are decreased intracranial adaptive capacity related to decreased cerebral perfusion pressure or increasing intracranial pressure, risk for ineffective cerebral tissue perfusion, and risk for disuse syndrome related to altered level of consciousness, immobility, and altered nutrition. Late manifestations of increasing intracranial pressure are respiratory and vasomotor. So you may see constriction or dilation of the blood vessels. Again, vital signs, you may see an increase in systolic blood pressure, widening of the pulse pressure, and slowing of the heart rate. Pulse may fluctuate. It may fluctuate from tachycardia to bradycardia. Temperature may also increase. And again, Cushing's triad is bradycardia with hypertension and bradypnea, which is decrease in respiratory rate. Patient may have projectile vomiting. You may see a further deterioration of the level of consciousness. Also, you may see decortication, decerebrate posturing or flaccidity, or hemiplegia, which is paralysis of one side of the body. You may see respiratory pattern alterations, which include Cheyne-Stokes breathing, as well as arrest. You may see loss of brainstem reflexes, as well as pupil, gag, corneal, and swallowing. Again, important to assess level of consciousness. You're going to be utilizing the Glasgow Coma Scale, which is the best motor response, best verbal response, and opening of the eyes. GSF of 8 or less generally means coma, and higher, the highest that the GCS goes is 15. That's a fully alert patient. And again, you're going to be assessing pupils and assessing cranial nerves. Test unconscious patient for pain response by using the sternal area. If no reaction, increase the pressure. Test all 4 extremities for strength. Again, you're assessing vital signs. Very important. Assessing their motor strength, grips, and flexion as well. Nursing process, again, assessment. You want to obtain history of events leading to the illness. Evaluate the mental status and level of consciousness. Assess selected cranial nerves and assess cerebellar function, reflexes, motor, and sensory function. Assess Glasgow Coma Scale, pupil checks, frequent vital signs, as well as assessment of intracranial pressure. And other nursing diagnoses that you may see as ineffective airway clearance, ineffective breathing pattern, ineffective cerebral perfusion, fluid volume deficit related to fluid restrictions, risk for infection related to increased intracranial pressure monitoring. You want some goals. You want to maintain patient airway, which of course is your number one goal. Normalization of respirations, adequate cerebral tissue perfusion, which is very important. Respirations, fluid balance. You want absence of infection as well as absence of complications. And next, you want to continue to monitor the respiratory status and lung sounds and measures to maintain a patent airway. Head of bed is elevated anywhere from 0 to 60, but usually anywhere from 30 to 45. Follow your provider orders. Avoid hip flexion. Avoid the Valsalva maneuver. You don't want to increase the pressure anymore. Assess for abdominal distension or other stimuli that may increase intracranial pressure. You want to help maintain a calm, quiet atmosphere and protect the patient from stress. And overall, these patients need very close assessing and monitoring of the neurological system and will most likely be in the ICU. And again, you may be monitoring the intracranial pressure via ventriculostomy or intraventricular catheter. The ventriculostomy can also allow for CSF drainage to occur to get that extra fluid off. Ventricular catheter is used for can be used for administration of medications as well. You may be giving IV mannitol, which is an osmotic diuretic medication, helps to reduce the blood viscosity by increasing cerebral blood flow, and the osmotic gradient moves fluid from the brain tissues to the blood vessels, and thus helps get it taken out of the tissue so we can decrease that pressure. Hypertonic saline can also be used and also creates an osmotic gradient, pulling in that extra fluid into the blood vessels. Dexamethasone may be used to help decrease swelling of the brain and also helps to decrease agitation, pain, and fever as it increases metabolic demands, which can also increase intracranial pressure. So again, very close monitoring. So that concludes the intracranial pressure information. Again, I wanted to go over that now because, again, we're going to be looking at strokes and brain infections and brain abscesses and brain tumors and head injuries and all that kind of thing, where in all those diagnoses you may see problems with the intracranial pressure increasing, and so I thought it was important to kind of spend a little bit of time, on that. So moving forward, we're going to be taking a look at seizures. Seizures are considered abnormal episodes of motor, sensory, autonomic, or psychic activity, or a combination that results from a sudden, abnormal, uncontrolled electrical discharge from cerebral neurons. There is different classification of seizures. Partial seizures begin in one part of the brain. Simple partial seizures, the consciousness remains intact, and the patient may have muscle contractions of the face or just one side of the body. Complex partial seizures, patient may lose consciousness. Most common have repetitive, non-purposeful activities such as lip smacking, picking at clothing, counting out change. Generalized seizures is where the whole brain is involved and consciousness is always impaired, and the patient will have contractions and rigidity of all the extremities. And again, the patient will lose consciousness in a generalized seizure. Not in all cases, though, of the like the partial seizures. So again, seizures are electrical disturbance or dysrhythmia in one section of the brain. These cells emit abnormal, recurring, and uncontrolled electrical discharges. And epilepsy is a group of syndromes characterized by unprovoked recurring seizures that affects about 3% of the people during their lifetime. Advances in epilepsy using the EEG have helped with diagnosing epilepsy. Epilepsy can be inherited, but not always is the cause known. Epilepsy can follow birth trauma, head injuries, infectious diseases, carbon monoxide toxicity, lead poisoning, fever, drug or alcohol intoxication, brain tumors, brain abscesses, as well as congenital malformations like an AVM. And there are about 1 million women are diagnosed with epilepsy a year. Women are at increased risk due to menses, and the effectiveness of birth control is decreased with anti-seizure medications. So any woman, younger women that you are caring for that are on anti-seizure medications, you want to make sure that they understand that, and they want to make sure they talk to their physician if they are wanting to try and get pregnant. So the risk of congenital fetal anomaly is 2 to 3 times higher in women with epilepsy. There may also be bone loss associated with women with long-term use of anticonvulsant medications. Approximately 2.2 million people have active epilepsy, and there's about 150,000 new cases diagnosed each year in the United States. It's the fourth most common neurological disorder. It is higher in younger children and older adults, and more common in African Americans, as well as socially disadvantaged populations, and more common in males. It is the fourth most common, I already said that. People with Alzheimer's disease or who have had a stroke are at high risk for developing epilepsy. Okay. And again, seizures can result from a CVA or brain tumor as well. And some specific causes of seizures can be cerebrovascular disease, hypoxemia, fever, particularly in children and mainly in children, head injuries, hypertension, central nervous system infections, metabolic and toxic conditions, brain tumors, people undergoing drug and alcohol withdrawal, and some allergies. But in about 70% of cases of seizures, the cause is unknown. Messages from the body are carried by neurons of the brain by discharges of electrochemical energy. These impulses occur in bursts when a nerve cell has a task to perform, and these cells continue firing after a task has been performed. Part of the body may be controlled by errant cells and may perform erratically, such as what happens in a seizure, and many times the patient will involve loss of consciousness. Okay. And again, epilepsy is a group of syndromes characterized by unprovoked recurring seizures. And again, most of the time we don't know what the cause is going to be. And as you can see, I've listed several causes there that I've already gone over. So you want to make sure that you're getting a good health history and physical and a good neurological assessment. An EEG is done as well, and an MRI may be done to detect any structural lesions such as a brain tumor. Women with epilepsy have increased seizure activity during menses, and again, the effectiveness of contraceptives is decreased by anticonvulsant medications. There is also bone loss associated with long-term use and should be monitored for. Okay. So caring for the patient, again, you observe and document the patient's signs and symptoms before, during, and after a seizure. Nursing actions during seizure for patient safety and protection. After seizure care to prevent complications, and there is a chart on page 1998 that goes over these. So as a nurse, you want to observe and record any signs and details related to the seizure, as well as before the seizure, and any visual, auditory, tactile stimuli, emotional disturbances, assessing sleep and hyperventilation. Is there a presence of an aura, which is a warning sensation of an impending seizure? Not everyone gets an aura, but many people do. What type of movements are involved, areas of the body that are involved, what is their temperature, improving gas exchange, suction or encourage coughing cautiously, but do not put a suction catheter in the patient's mouth while they are seizing. And again, watch your elderly patients because they are at an increased risk for seizure activity as well. So pre-ictal is the oral before the seizure, ictal is during the seizure, and post-ictal is after the seizure. So pre-ictal, does the patient have any aura of seeing lights, any odors or noise? Ictal, protect the patient, privacy, use pads on the bed and floor, loosen clothing. So ictal is during the seizure, of course, too. So take off glasses, place the patient on the one side if possible. And the post-ictal is you want to keep them on one side to prevent aspiration, help to reorient the patient and make sure the airway is patent at all times. And nursing diagnoses, risk for injury, fear related to possibility of seizures, ineffective coping related to stresses with coping and knowledge deficit. And again, you want to prevent seizures, reduce fear of seizures, and improve coping skills as well as education. Status epilepticus is a continued seizure activity that lasts, actually it lasts anywhere from 5 to over 30 minutes. It is considered to be a neurological emergency. It can cause brain damage and respiratory distress may be present. And again, causes brain tumors, lesions, infection. Keep the patient safe. Administer IV solutions. Administer oxygen. Treatment may be IV Valium, IV Ativan, and IV Dilantin. Phenobarbital is usually used following these drugs because it's a more longer-acting drug. 50% dextrose may be given if possibly this is from hypoglycemia, and thiamine may be given if it's caused by chronic alcoholism or those people undergoing withdrawal. And status epilepticus is a state of continuous seizure activity or a condition when seizures recur in rapid succession without return to consciousness between seizures. And again, it is a neurological emergency. The brain uses more energy than is supplied. The neurons become exhausted and cease to function, and permanent brain damage can then result. The longer a seizure lasts, the less likely it is to stop without drug therapy. And status epilepticus is again considered to be a neurological emergency. Stay with the patient. You'll be administering medications, IV medications, particularly IV Ativan and IV Ativan. That's right, IV Ativan, and I don't know if I said this earlier. IV Valium may also be given. Okay. So that's why you want to always maintain a patent IV, because you may be giving those drugs if the patient is in status epilepticus. And again, these patients may experience severe injury and death from trauma during a seizure. Patients who lose consciousness during a seizure, of course, are at greatest risk. People with epilepsy have a mortality rate 2 to 3 times the rate of the general population, and SUDEP is sudden, unexplained, or unexpected death in epilepsy. This is higher in males. Of deaths related to epilepsy, 40% are due to accidents during seizures. Patients may commit suicide or death from another underlying disease, and they may have the sudden, unexplained, or unexpected death in epilepsy. Higher in males. Cause is relatively unknown, but they think it might be related to respiratory dysfunction or cardiac dysrhythmias. So you make sure you do really good medication teaching with these patients so they just don't abruptly stop their anti-seizure medications, because that can throw them into, a very serious status epilepticus. So make sure your patients understand about the drugs, and if they do have issues or side effects, make sure that they call their care provider so that the care provider can work with the patient and choose another anti-epileptic drug if they feel like that's the best way to go. There's so many different drugs, though, so I think they can usually find something that they can substitute, maybe that has less or fewer side effects. So medical management includes drug therapy, seizure control with the fewest side effects with these drugs. Meds control but do not cure epilepsy or seizures. Treatment usually starts with one drug and may need to be adjusted or other drugs added to gain control. Drugs that are used can be Tegretol, Klonopin, Dilantin, Keppra, Topamax, phenobarbital, and Depakote. You want to stop the seizures as soon as possible. You want to ensure adequate cerebral oxygenation and maintain the patient in a secure state, adequate airway and adequate oxygenation. Surgical management may be needed if seizures occur due to a brain tumor, cyst, or other vascular anomaly such as AVM. If seizures are located in a well-circumcised area of the brain that can be excised without producing significant neurological deficits, then they may remove that area of the brain to produce long-term control and improvement of seizures. When seizures don't respond well to medications in the adolescents and adults with focal seizures, where seizures are limited to one hemisphere, then a vagal nerve stimulator may be implanted under the clavicle and then connected to the vagus nerve, and it delivers electrical signals to the brain to help control and reduce seizure activity. There's also another neurostimulation system, whereas a surgically implanted device with electrodes that sense and record brain electrical activity. Electrodes deliver an electrical stimulation to the location of the seizure origination within the brain, and it works by interrupting brain wave activity before a seizure occurs. The primary treatment for seizure disorders is again the anti-seizure, anti-epileptic drugs. A cure is not possible, but the goal of therapy is to prevent seizures with minimal toxic side effects from the drug therapy. And the drugs generally act by stabilizing nerve cell membranes and helps prevent spread of the epileptic discharge. Drug therapy should begin with a single drug based on the patient's age and weight and type, frequency, and cause of seizure. Dosage should be increased until seizures are controlled or toxic side effects occur. You may also be checking the therapeutic range for different drugs such as Dilantin. You do not want the patients to experience toxic side effects, but you also don't want the levels to go below the normal range, because then they may continue to have seizures. So you do need to make sure that you're understanding what needs to be, the different drug levels that need to be drawn. And if taken properly, medications can control seizures in 70 to 80% of the people. And there's also carbenzapine or Tegretol. Side effects are dizziness, drowsiness, unsteadiness, nausea and vomiting, diplopia, mild leukopenia. Toxic effects may be, and nursing considerations are severe skin rash, hepatitis, blood dyscrasias. Monitor CBC and iron weekly during the first 2 months and yearly due to potential bone marrow suppression. Do not take with grapefruit juice. Clonazepam or Klonopin, side effects are drowsiness, behavior changes, headache, alopecia, excessive hair growth, palpitations. Toxic effects are hepatotoxicity of the liver, thrombocytopenia, bone marrow failure, ataxia. Nursing considerations, you're going to want to monitor the CBC and liver function tests as it may cause elevated bilirubin, AST, and ALT. Gabapentin or Neurontin, side effects are dizziness, drowsiness, somnolence, fatigue, ataxia, weight gain, and nausea. Toxic effects may be hepatotoxicity. Nursing considerations may be leukopenia, which is a decrease in white blood cell count. There's also one called Keppra, and I'm not sure how to pronounce the generic name of this. The side effects are somnolence, dizziness, fatigue. Toxic effects are unknown. Nursing considerations, you want to monitor the CBC as it may cause a decrease in red blood cells and white blood cells, as well as abnormal liver function tests, which is in about almost all these drugs. And again, if meds don't work, then they may do one of those surgeries that I previously mentioned. Dilantin, of course, is the drug that we see used most frequently. Side effects can be visual problems, excessive hair growth, excessive gum growth, dysrhythmias, dysarthria, and nystagmus. Toxic effects can be severe skin reactions, peripheral neuropathy, ataxia, drowsiness, and blood dyscrasias. You need to monitor the CBC, calcium, albumin, and hepatic function test prior to and monthly for the first several months, and then throughout therapy. Topamax side effects are fatigue, somnolence, confusion, ataxia, anorexia, depression. And weight loss toxic effects are nephrolithiasis, so stones. Nursing considerations may cause anemia and elevated liver function tests. Okay. And the elderly have a high incidence of a new onset of seizures. You have to be more careful of their medications being used as the elderly metabolize much slower and liver function may be decreased, and there may be an inability to metabolize the drug as well. Phenobarbital and mycilline affect cognitive function, and Tegretol has many side effects. Gabapentin and Keppra are safer and have fewer side effects. Trilipto and topiramate are safe as well. But you want to monitor these medications and monitor these patients very closely, particularly for side effects that you may need to talk to the doctor. Okay. Oh, and also promotes again some things about promoting safety measures. If it is a child, they may need to wear a helmet if there is a risk for head injury. Again, diet, exercise, and assist to identify events or situations that will precipitate seizures and avoid if possible. And just help the patient to handle the stress of seizures and make sure they understand why they're taking the medications and how they need to take the medications, which is very important, and if they need to have lab work drawn. And did you know that there are seizure response dogs that receive special training to assist those in distress and having seizures? They can find help if the owner is in trouble. They can pull away objects that pose danger, and they can carry information about their handler for emergency response teams, as well as providing emotional support, which is pretty cool, I think. So now the cost to get and train a seizure response dog is up to $20,000 and up, but they provide the dogs free of charge to recipients. You just have to go online and fill out the application. And there's also Pause with a Cause offers a program, and you can check the American Dog Trainers Network's listing for programs in your state. So that is now the last of the seizure material. So today we looked at the increasing intracranial pressure as well as seizures. This now concludes this lecture. Thank you.